Okay.
Hello everyone, welcome back to Hot Seat Season 3. I'm Omid Moghaddas joining you from Tehran. And once again, I'm so blessed and honored to have the chance to share this educational platform among my dear friends and great educators from around the world with all of you sitting at your home. 24 hours a day, you have the chance to enjoy listening to these amazing speakers and learn from them. And I have to say, it's a real great opportunity for all the practitioners interested in perio and implant dentistry to learn from these great educators. As you all know, over the past 2 seasons, we talked about different aspects in implant dentistry. But as you know, again, some aspects are very challenging, and it's very worthy to learn and hear the expert opinions on the techniques, on the details. And bone reconstructions is among those topics. And today, a very, very talented surgeon, a great educator, and I'm so proud to call him my friend, Dr. Robert Siva, is here with us from Brazil. Hello, Robert, and welcome to Hot Seat, my friend.
Hello, Omid. It's my pleasure to be with you here. And finally, I'm here. I've been following you for such a long time, and I really wanted to get to the day where I was invited. So here I am. Thank you.
So much, my friend. It's our pleasure, and truly, I was looking forward to this day. And now finally, we are here in this platform. Dr. Robert Silva is going to talk about the important aspects in bone reconstructions and three-dimensional ridge reconstructions, which I believe is one of the most demanding topics in those interested in implant dentistry. And I have to say, it's not a compliment, it's a truth. He's one of the most super talented surgeons in this field. And I think you all are so lucky to hear from him in this platform, which is available for most of you around the world. And before we start, I would like to have a very short CV of Dr. Robert Siva for all of you. I know you all are familiar with him, but as a tradition, I would like to have his CV. And then as a routine of Hot Seat, we will go through the presentation and we will have a discussion for sure on the topic. Dr. Robert Siva received his dental degree from, I hope I pronounced it right, Uberlandia Federal University in 1994. He's a board certified in periodontics at the Brazilian Association in 1997 and completed his master in 2002 and PhD in 2004 at Piracicaba Dental School, Campinas University. He was the first recipient of the first edition of the Bud Tarson Award granted by American Academy of Periodontology in 2005 and one of the winners of the Growth Against Recession aesthetic case competition in 2011. He is also a professor at the Implant Perio Institute Research and Advanced Dental Training in Sao Paulo, Brazil, and is the author and co-author of several scientific publications and chapters in textbooks with emphasis on periodontal tissue management around teeth and implant. And I have to say, he's the author of one of the greatest publications in the field of reconstructions aesthetically, especially in implantology, and the book is called Aesthetic Perio Implantology by Quintessence. I truly recommend you all, if you are a bone guy, if you're interested in reconstructions, you should read this book. And I'm pretty sure when you see his presentation, you will be mesmerized by his skills. And I don't know what to say anymore. I won't wait you all much longer. And Robert, the platform is all yours. You can share your screen and we can enjoy your presentation.
Thank you very much for the very nice introduction you did. It seems that I'm even better than what I am. So it's not that good, you know? I'm not that good at all. I'm just a clinician that really enjoys sharing the information and trying to create protocols in a way that makes our life as clinicians easier. So this is pretty much about what is about the implant perio concept and philosophy, trying to create this kind of decision trees for everything that we do that shall help the clinicians in a good way. So today, again, with the little time we have, I always like to try to teach something. I don't just want to go there and show a good case or give a show. This is not what it is about. I think the most important thing as a educator is trying to really provide a good information that can teach and help people to do the best. So this is what I'm going to try to do here today on the topic of bone augmentation. Okay, so now I'm going to share my screen. I hope you can see my screen here. Can you see it? Okay, so this is it. So let's get to the point. So the topic of my presentation is three-dimensional radio augmentation, limits and predictability of this procedure. So is that important? I think it is, because if you work in the clinical practice every day, very now and often, you're going to see clinical scenarios that it's kind of impossible to place the implants at all because there is no bone, or it's like very difficult to place implants in the three-dimensional position. So for that situations, we must think about performing the guide or the bone augmentation itself using the technique that you want. And it is true that there are several alternatives to do our clinical procedures of augmentation. I have no doubts that these two kind of procedures that you can see in our screen are probably the most widely used alternatives. We can use the autologous bone blocks, which is gaining nowadays a lot of attention again because of the bone plates or the Curie technique that is very good. But the other alternative is the guided bone regeneration that relies on the placement of a membrane covering the edges of the defect, and underneath we're going to place our bone graft. But in my humble opinion, the guided bone regeneration is the most versatile of all techniques, because I don't care about the shape or the design of the defect, because it's always possible to cover the edges of that defect, upper, lower, anterior, posterior, horizontal, vertical, smaller, bigger, I don't care. It's always possible to cover that defect with a membrane. And that will facilitate the ingrowth of vessels around the particles of our biomaterial that is going to be placed underneath that membrane. And that makes this kind of procedure extremely predictable. But don't get me wrong, predictable does not mean to be easy. So in fact, this is a very, very difficult clinical procedure, and it's very sensitive. So whoever is there trying to use this technique have to be aware of the indications and the contraindications and the limits of the technique and how to do every single step in order to create a good pathway towards success using this technique. So as I mentioned, so guided bone regeneration is associated with this biological principle, which is the osteopromotion, which essentially means that a barrier or a membrane, and there are different membranes out there, that will cover entirely the edges of our bone defect or deficiency, and that would allow the cells from the bone marrow or the recipient site, and even if there are teeth associated to the area, the periodontal ligament cells originated from that area will repopulate this area underneath the membrane, and through time will make it possible to grow bone into that area. So that is essentially what guided bone regeneration is. But every single step in this procedure is quite important. So from the incision to the suture, every single step is extremely important. And if you make one single mistake, Omid, in this kind of procedure or in any one of those steps, that is an open door to failure. So this is not for every clinician and not for every patient. So in terms of the patient, we have to find the proper patient that really want to go through that and are healthy good tissues, good health, and good mindset to do this kind of procedure. And in terms of the clinician, there is a learning curve that has to be developed in a way that we can do a good work in this kind of situation. And if you do everything right, in the end, after several months, we can reopen the site and be astonished with the amount of new bone that we can find and the quality of the bone that is underneath that membrane. And eventually, we take trifines and small cores biopsies to see what's going on. And what we see here is a new bone formation, so new living bones around the particles of our biomaterials. So pretty much a good area to place our future implants. And if you do everything right according to the book, okay, so it doesn't matter if I work in the upper jaw or in the lower jaw, anterior or posterior, in association with those very big localized defects, as you can see here, we are going to be able to recreate a very nice amount of bone that is three-dimensional, living bone, hard bone that can be used to be drilled to place our implants in the prosthetic-driven position, and this bone will stay there through time and will support the soft tissues. And as I mentioned, there are several articles discussing how to do this kind of procedure, but I really like this quote by Dr. Titi, who is one of the godfathers of this procedure, that says that success in guided bone regeneration relies in a very strict obedience of the surgical technique. So from the incision to the suture, it's very important. And here, I'd like to highlight the selection of the membrane that we should use and the biomaterial that I have to choose in order to have such nice outcomes. So the very first thing is to select the selection of the membrane. But the selection of the membrane is not random, okay? It is defect directed. So depending on the configuration of the defect, I'm going to select one or other membrane. So to do that, I have to understand the anatomy of our deficiency. And there are two kinds of deficiencies when we're talking about this kind of localized defects. I can have either a vertical or three-dimensional defect, which essentially means that there are bone peaks more coronal to the base of our defect itself, meaning that the line that connects one bone peak from one side to the other bone peak to the other side is not a straight line, but a curved line. That essentially means I have a three-dimensional or vertical deficiency. On the other hand, when I'm talking about a horizontal defect, it pretty much means that that vertical component is not present at the configuration of our deficiency, and the line that connects one side to the other is a straight line, not a curved line. So this is number one. And number two, we have to define the horizontal deficiency is favorable or not favorable. And to do that, we must see the Cbct of that patient, of that region. So essentially, I can have unfavorable deficiency, also known as a knife edge situation, meaning that there is no medullary bone in between that corticals that are actually connected to each other. So this is why we call paper thin bone or knife edge, because there's no space in between those corticals that become one cortical only, as opposed to the favorable situation where we have a medullary spaces in between the the buccal and the palatal plate of the bone. Okay, why is that favorable? Because we have the medullary bone that has the cells, the growth factors, and of course a lot of growth vessels that will can come to the area. So vessels, growth factors, and cells. And we now have to decide what membrane I'm going to use. So if I have a horizontal deficiency, which is favorable, there is no need to use something more sophisticated rather than a collagen membrane or a resorbable barrier. Of course, that you can use other devices, but that is meaningless, because the only thing you're going to get by using more sophisticated materials when you have a very easy case to treat is the likelihood of complications. So try to keep it simple as much as you can. On the other hand, when you have unfavorable horizontal deficiencies, because the resorbable material can resorb too fast, then you can use or either long-term resorption membranes, okay, like Creos, for instance, or other kind of membrane which are resorbable, or many people would tell you to use non-resorbable barrier membranes because we must have more time to heal the bone. And of course, when we're treating the vertical deficiencies, we must always use something that is stable. Okay, it's a framework that is stable, that will keep the graft underneath with a lot of precision and stability, and that is very important for those vertical deficiencies. So very easy. So vertical and horizontal, we have to define what membrane you're going to use, and I think this slide pretty much shows the possibilities that we have. But underneath the membrane, it's very critical and important that we select a good graft. And especially for the verticals, okay, especially for the verticals, and especially for the more demanding cases, it is critical to use autologous bone as part of your grafting selection. So the bigger the case, the more autologous bone you will need to really induce the regeneration process. So pretty much in a general sense, we like to add at least 50% of autologous bone and about the same quantity or a little bit less of your choice of biomaterial. I like to use the xenograft. So here in Brazil, we have this material very popular. So everybody likes to use the xenograft. I like to use BIOS, the small particles, which is known to be very osteoconductive, and this material not resorb through time. So we have like a perfect synergy between those two materials. One, the autologous bone, will have the induction of bone formation, and the other will decrease the morbidity related to the bone harvesting, okay? And on the other hand, will create the stability of the long term of this regenerated bone. So this is the kind of material that we like to use. And of course, that there are different ways to collect that bone. So different kinds of auto chip maker burrs, which are burrs that can collect bone during the rotation, which are very effective. I like them very much. My first choice, as a matter of fact, are the bone autologous bone chip burrs collectors. The second possibility is the bone scrapers. There are different kinds out there, disposable and not disposable. So it's up to you to define which one is better suited for you. I like those very much. And eventually you can use a bone graft, a bone block, if you will. So you can use the piezo today to harvest a good piece of bone from the ramus, for instance, and then we can really grind that bone in the grinder machine that will also provide the particles of our material. And this is the moment that you can add whatever biologics that you want. So in my perspective, I do not change the graft material. I'm going to use autologous bone as the first most important player and the biomaterial. And in this moment, if you want, you can add any of those biologics to boost the healing of that area and create more possibility to bring cells and growth factors and vessels to that region. So you can use BMPs, you can use recombinant PDGF, which is very, very good. And you can use something cheaper, which is the blood-borne products. And I like very much the blood-borne products like PGF, PRGF, or LPRF, because that will provide me the possibility to do the sticky bone. And by using the sticky bone concept, it's not that I want to create more bone. It's the fact that it makes my life much easier to really pack the graft into the site, which is very, very important to our procedure itself. So this is why I like so much the blood-borne products, because of the sticky bone appearance that I can have, which helps me a lot during my clinical procedures. And this is not about growing bone. It's about changing the life of our patients. So here you can see 3 different patients with different perspectives, with different backgrounds, but they share in common one single feature, and that is the absence of some bone that prevents them to place, implant-supported restorations that would affect their aesthetics, their self-esteem in a broad way. So by doing the guided bone regeneration, we could increase a little bit or more the bone of those deficient regions that now allow these patients to have implant-supported restorations that would not only restore the bone, but the self-esteem and the aesthetics and the confidence of those patients. So this is pretty much what this is about, changing the life of our patients, not only on the functional aspect, but in the tactical aspect and emotional aspect as well. So having said that, now I can jump to my clinical case that unfortunately is not completed yet, but it's very close to the end right now, and it could not be finished because of the pandemic, but I'm pretty sure you're gonna like this clinical case that I prepared for you. So this is a young patient with a very high smile line, as you can see. She has a lot of gingival recessions, and for sure you have already seen that she has here some artificial gingiva in this region. And what happened here is that unfortunately she has lost those 3 anterior upper left teeth, so the central, the lateral, and the canine from the left side of her mouth due to an accident. Okay, and obviously you can appreciate that has a very big impact on her aesthetics and her self-esteem of that area. So we can also see that because she has lost a significant amount of bone in this region, there is some collapse on the lip on the left side because of the lack of the bone to support that region. So this is the clinical image, the internal clinical image, and this is the x-ray. And the moment I put my eyes on this picture, because a friend of mine, Dr. Alexandre, who saw this patient, he called me to tell me what was going on, and he sent me those pictures. And I saw in the very first moment that something was already happening here on the apical area of the right central incisor. And the panoramic views shows that there is something going on here, and there is a big deficiency here on the adjacent region. So when we have the x-rays, we can already see that this tooth here is already compromised. So another thing that we can observe in the periapical image, which is very important to have as a diagnostic tool, is to see the difference in the height of the interproximal bone on the adjacent teeth. So in the central incisor, you can see that there is a recession here already, meaning that there is some proximal bone loss in this region, but not on the mesial aspect of the distal aspect of that tooth, meaning that we have to consider if this tooth is a good candidate to stay in the mouth, regardless of the presence of this situation here. So many times the tooth is okay, but because of the discrepancy on the height of the bone, we shall sometimes tell the patient that the tooth has to be pulled out. Okay, on the same thing on the other side, but there is a lesser discrepancy on the premolar. And this is the Cbct that pretty much shows that there is a big resorption here. And of course, this tooth has to be taken out. And we can see a big foramen, palatal incisal foramen here that has to be considered to be removed as well. And of course, the defect itself. So the very first thing to do here was to take out the central incisor because it was hopeless. And this is a very bad moment to do any strategy of reconstruction because of the infection and because of the poor quality of the soft tissue here. So we decided here in this area just to take it out, to clean, and to use a collagen sponge to help the blood clot to form in this region and wait a couple of months. So this is the patient after 2 months. And this is the moment that I really saw the patient for the first time, like clinically. So I asked my friend, Dr. Alexandre, to take out the tooth and to talk to the patient. But this is the moment that I came to treat the patient to do the ridge augmentation procedure. So we can see here now the soft tissues are completely healed. Okay. One extra tooth was positioned here at her fake orthodontics just to bring some aesthetics to her. And of course, that I can see here that she has a very good amount of keratinized tissue, which seems to be very thick tissue with a good amount of keratinized tissue. So that is a very good scenario to work in. So we started our procedure right now. I'm going to a small video to show you how it was done. But it's important to understand that our incision line was performed a little bit to the buccal area. And I know many people out there would do the incision to the palatal area. And I don't think that's a good idea. And then we have some time, we can discuss that specifically. But I did the incision towards the buccal in association with 2 vertical release incisions in the most distal aspects in such a way that I can expose the bone as we are seeing here. So this is the outline of the incision. So a little bit towards the buccal, so intrasulculars, and then 2 vertical release incision in the palatal area, in the most distal area, to have a very good view of this region. All right. In the palatal aspect, intrasulcular incisions, 2 or 3 teeth away, just to create the space for us to work. So having said that, now I can show you the Cbct of the patient, which shows pretty much a very big deficiency here in the anterior zone of this patient. You can see that it's paper thin, like here in the crest, very, very thin ridge, and the absence of the buccal bone completely. And that was what was really preventing the lip to have support. So it's not only vertical, but also horizontal. And I really like to do this kind of play here using a printed model to see the anatomy of the area. That will give me the idea of how much bone I have to collect. In this case was in the ramus of the patient from this area here on the right side that I took the bone from, okay? And this model provides me the idea of how much bone I have to collect. And I like to do a kind of waxing of the future bone, okay, that I might need according to the bone peaks in the vertical direction and the buccal and palatal dimension of the adjacent teeth. So that would bring me a kind of 3-dimensional view of what kind of bone was there before the traumatism that the patient had. And that can also help me to create the membrane shape beforehand. Before I go to the surgery, I have an idea of some templates that I put then to sterilize. And in the time of the surgery, I just trim the membrane, the real membrane, on top of that pre-customized frame that I have used. So here I'm already elevating the flap. You can see the configuration of the defect, and here I'm removing the nasopalatal content creating the cleanness of the area. And here I'm performing the decorticalization or perforations to help the blood to get in. So here I'm using the tenting screw, and please observe that the height of the head of the tenting screw is lined to the interproximal bone adjacent to the defect, which is very important. So here like a 7mm defect. So you can see now that I have here my template that was sterilized, okay? And observe that I'm changing my gloves here to touch the membrane. Whenever I'm doing the membrane stuff, I change my gloves to avoid any kind of contamination, okay? So I'm opening my membrane. Here I used a cytoplast titanium reinforced barrier membrane, and using that that foil, I was able to cut the membrane in the best position possible. Here I'm using some screws to stabilize the membrane on the palatal side. So I like to stabilize first on the palatal side. In this case, I used 3 screws. And now my graft choice, 50% of autologous, 50% of xenograft. Maybe in this case, 60% of autologous bone was used because of the magnitude of that defect. And now I'm very, very slowly and calmly adapting the bone graft to its position, trying to overcome the deficiency, not only the vertical, but also on the horizontal dimensions. Please observe that I do not place the graft in the most apical region, which is a very common mistake people make. Because if you place the bone graft at this region, where the membrane is going to sit to be stabilized. So it's very important that to keep like a 3mm area exposed of free bone so that you can adapt your membrane. So a very critical part here is the folding of the membrane on top of the defect. Try not to move the particles of the biomaterial. Here the first screw was placed, now a second one in the middle, and a third one on the other side. You can see that the membrane is a little bit loose, so I put another screw there. And now is the time to fine-tune the shape of our membrane in a way that we don't have any touching of this kind of membrane towards the root, okay? And here you can see that because I have some space here, I'm using that space to put a little bit of more bone to increase this area just below our membrane. And of course, this is the moment that my heart really beats faster, which is to release the flap to really be able to close this in a tension-free way. So in these procedures, my heart beats fast 2 moments. When I'm placing the membrane, because it's not easy to really position the membrane in the best way. And the second moment when I'm starting to free the flap in a way that I have a tension-free closure. So very important. And please observe, Omid, that here I'm also using a collagen membrane on top of the cytoplast. And a lot of people question that, but you could see that I'm going to return here just a little. You could see here that there are some spaces here between the membrane and the root, and some particles of the graft is exposed. So through that area, some connective tissue can get entrance. So I want to block that. So to avoid this kind of situation, I'm always using a collagen membrane just to cover the edges of my barrier, which is the important one here, which is the cytoplast, but just to protect that tiny little areas on the adjacent regions. And if you have used the LPRF, and as in this case, I also like to protect everything to really foster the healing of the area. So here you can see the closure of the region, which is very good because you can see that the tissue is like this, not like this, but like this, which shows that the release of the flap was good. A clinical picture showing exactly what I just mentioned. So it's like this. And you can also see that the vestibule has been shifted to the coronal direction, which is something that always going to happen in this kind of procedure. So after 21 days, the last suture was removed. So I like to remove sutures between 14 and 21 days. And this is really when we start to relax, because, you know, I always tell my students that I can wait 9 months easily after a surgery like that. But the period between day number 1 and day number 21 are critical for me, because I want to see during this time a very nice healing of that area. And this is exactly what you are seeing right now. And if nothing happens here from this moment to 9 months of waiting, which is the time that we like to wait, we're going to probably have a very nice and uneventful healing period. So you can appreciate again that we had to cut a lot of the cervical region of the prosthesis of the patient to accommodate that tissue that was brought in the coronal direction. And you can also appreciate that the volume horizontal that we were able to create at this moment. Of course, that we have to wait a lot of time. So this is the 9-month healing, which is uneventful, no exposure, no infection, nothing happened. So of course, that a very big deviation of the mucogingival line, but pretty much a beautiful outcome in terms of what is happening below this area. And of course, we have to see what's going on. And this is the moment of the truth, where when we actually see the Cbct of the patient. And I was extremely happy. I couldn't be happier when I saw this x-ray, because you can appreciate with me that I have here like a horizontal view of this area, proving that I was able to grow as much bone as the tenting screw was positioned, which was lined to the interproximal height of the adjacent teeth bone, okay? And more importantly, I was able to create this volume of bone that was really, really impressive. You can see here in the horizontal views of this area, as well as in the occlusal view, that the bone was very, very thick, as opposed to the very thin area that we had in the past. So here, at this moment, we are reopening the site to see the bone quality. So here in this small video, I'm just showing the way we elevate the flap with a lot of care, not to harm anything. And this is when we see this whitish appearance, which is so important, because if it is whitish, it means that there is no infection, and probably you're going to have a very good quality of the bone underneath. And here we are removing the membrane, which has to be performed in a very careful way again. So have to find all the screws and very slowly detach or peel off the membrane from the bone that was regenerated. And here on your left, you can already see the amount of bone that was able to be recreated. So it's amazing, the volume of the bone that has been grown here in this area in a very, very positive way. And you can see that what you put there stays there. So everybody would see this region here right now. And you can imagine that the membrane was folded in that area, because the biggest membrane that I had could not cover from one side to the other. So in the central area, we see the bone is completely there. And here, because of the membrane would not reach to the most distal aspect, now we have some drop of the bone, but see the volume of the bone that we had formed here. And anyone who has some experience would tell that this bone is very high quality because of the appearance that we have. And another important moment is that when we remove the tenting screw, we see this whitish kind of cortical just underneath. And that shows that the bone is really stable in that area. We can see here like a small covering of some soft tissue, which is like a half a millimeter that is here in this region. And this may be related, as Dr. Massimo Simeon has shown in one of his publications, due to some mobility, the minor mobility of the membrane, because of the tongue of the patient is really pressing this area and creating some mobility of the membrane that shall produce a small mobility of the graft. So that will not produce bone all the way top to that area. But below this, we have a lot of bone, as you could see in the x-ray. You can see here that the bone is very hard. And again, it's bleeding, which is important. And this area here again. So every now and then that you remove a screw from the bone, if you see this kind of cortical that is formed below the head, the internal part of the head of the screw, that means this bone is very, very hard. So I was extremely happy to see that. And now you can see the comparison. So this is the pre-op view of the defect. This is what I waxed in terms of the possibility of the bone. And this is what I could obtain. So much thicker bone. And I'm so happy because of the shape of the membrane that was positioned there. So extremely effective and important. And now a very important moment to define how many implants we're going to use. So here I have a young patient with a high smile line, but I have a lot of bone, and I can see that the distance from one implant to the other in the virtual world would allow me to place individual implants in this area. And of course, there is a lot of debate on this, but I felt really comfortable because of the waxing, the virtual waxing of this region, that I would be able to place individual implants. And if I regret someday to place 4 implants, I can just put one of those implants to sleep and recreate this kind of other situation in terms of the number of the implants. So I liked this idea here, and I decided to place 4 individual implants because, again, the distribution was very well suited to the gap of this region, and I could observe that the distance from one implant to the other would be okay. So of course I have used it here small diameter implants with platform switching associated to that. You can see that the drilling is quite amazing here. And after I drilled, the spacing was unbelievable in these situations. So I placed 4 implants. So in a guided way, so everything guided here. And after I placed those 4 implants, in these very demanding cases, I like to do some extra grafting here. So I placed it here 3 millimeters high healing caps. And on top of that, I did an over reconstruction using primarily xenograft with a small amount of autologous bone that I scraped from the adjacent region, okay? And some PRF that was taken. Please observe that I also used here some endogain, so ramelogenin, to help the healing of the periodontal apparatus of this patient. And then, of course, we closed the membrane and fixated it with tacks. So fixation on the palatal side, as well on the buccal side with a bioguide, just to protect the bone that was recreated in the first, session of regeneration. Here you can see that the design of the membrane was very good, and I don't want to over stretch this membrane just to protect the bone that was there. And now is the moment to close again. So again, this is a little bit more tricky from the first side, because now the soft tissues are a little bit already fibrotic because of the biomaterial that we used, but you can appreciate that we are able here to close without any problem. And this is the patient after 2 weeks, when the sutures were removed, were about to be removed. And this panoramic X-ray shows a very, very nice distribution of the implants. And of course, now we have to wait some time to heal this area. So this is how the patient healed. And again, more substance of the teeth have to be reduced to protect or to fill the area using the artificial teeth that was there. And you can see the amount of tissue that was missing. Now we had to cut the teeth of the patient, the artificial teeth, in such a way not to press anything in that area. And again, you can observe the magnitude of the horizontal growth that is taking place here. So now we don't have any keratinized tissue, okay? And that is something that we have to deal right now. So here, this kind of virtual, like a DSD was done here, trying to see how teeth would do. And we can see that we have a good feeling of the teeth in the area, in a way that it seems that we're going to have a good outcome in terms of the feeling of the soft tissues and the architecture of the teeth. So at this moment, we did a reopening, okay? So a second surgery, so to speak, to remove the short healing caps and put higher, taller healing caps. And in this moment, we did an extra soft tissue graft in a way that we could now improve the thickness of the connective tissue below the area. So not only I'm concerned about the amount of keratinized tissue, but I want to have a very thick connective tissue in this area, because that shall protect the bone, as has been cited by Linkevicius, for instance, and many, many others. So after the healing was done, we can see a beautiful volume of tissue here. Of course, no keratinized tissue. And because of the pandemic, we had to change, because now I'm not here with the patient anymore. So my colleague in Goiânia, Brazil, Dr. Alexandre and Dr. Erica, his wife, they decided to deliver the patient some provisional restorations at this moment, because the patient was very anxious because of the time and everything. And I personally think this is not the best moment. I think we should first develop the keratinized tissue and then deliver the prosthesis. But because of what happened, that was a decision. And here you can see the posts are being used here to scan the area. And of course, the lab work was done. So we can see beautiful virtual aspects of the teeth which have natural appearance, and those provisionals were delivered to the patient. And this is how the patient looks like now. So we can see a number of things. Number one, that the implants are very well positioned. Number two, that the volume is absolutely fantastic. Number three, that you can appreciate here from the central to the canine, that the soft tissue is filling completely this area. Number four, that the papilla here between the centrals is not as perfect as I wanted it to be. And number five, that we still have to develop the keratinized tissue. So this is how the patient is right now. So exactly how she started and how she's at this moment. And because of the pandemic, we were not fortunate enough to do the rest of the work. But I do want to tell you, your audience, what I'm going to do here to solve this case. So I still need 2 extra steps. The first step is to create the keratinized tissue. So I'm going to take this case here very shortly, okay? So this is before the reconstruction. This is after the reconstruction. So we don't have to see the bone here. I'm talking about soft tissue. So you can see that before and after, I don't have the keratinized tissue here. So this is what I'm going to do with that patient. I'm going to create sharp dissection. And this is the importance of first grafting with the connective tissue, because I want a very thick soft tissue on top of my implant, in a way that now I can sharp dissection the epithelium of that, put it in the apical region. So here I'm doing here the suturing in the apical. So this is the vestibuloplasty of this area. So in this case here, I'm doing the reopening at this moment, and I'm placing the free gingival graft in a way that I'm able to recreate here the keratinization of this region. So this is what I want to do to that patient. And in this patient here, you can appreciate that now I was able to recreate a beautiful amount of keratinized tissue, not only on the thickness, but also on the height. And still, in the last part of my procedure, I'd like to do this papillary graft that I'm working right now. So I'm doing a lot of cases of grafts below the papilla. So in this case here, as you can see, so there is a missing papilla here, distal to this implant that is here. And in the moment of the surgery, I'm going to do a crown lengthening and this kind of papillary graft. So 2 surgeries here right now, one on one patient, another one in the bottom of another patient, that I'm harvesting some tissue from the tuberosity and I'm placing underneath the papilla. So I create like a pouch using a special blade, as you can see in the top video, that I create a space, and below the papilla tissue, I graft this very, very tiny connective tissue from the tuberosity, and I find a way to suture it in the best way possible. So doing that, you can see here in this patient that I had no papilla here, and after some time I do have the healing of a nice papilla. Of course, that in this case here, my friend that took this patient did not take in the best way possible the picture, but you can appreciate the growth of the papilla here as opposed to this situation. Okay, and now coming to the end of my presentation. So I like to conclude here showing this view of another case. And I like to state that we have to do one miracle at a time. So first miracle, grow the bone. Second miracle, place the implants in a prosthetic driven way and simultaneous reconstruction of hard and or soft tissues. And the third miracle, to recreate the keratinized tissue. So this is pretty much what I like to do in my cases. So bone augmentation, implant and additional reconstruction, vestibuloplasty and keratinized tissue, okay? And the outcomes are there. So many cases like follow-ups, like in this case, 10 years of beautiful growth of bone. Another case, 16 years, pretty much shows that it's possible to recreate the bone in the best way possible. So it's doable, it's possible, but it's very sensitive and it's predictable, but requires multiple procedures. So we have to consider the morbidity and the time and the cost of the treatment. And this is not for every patient, not for every dentist. So we have to put ourselves in the learning curve in a way to do this kind of cases. And with that, I thank you very much for this lecture. I'm sorry that I'm 50 minutes here. I'm sorry. I was supposed to speak in 45, but life is life. And this is my group, Implant Peri group. Okay, and this is the book that Omid was telling you about. So I hope that you have the opportunity to take a look at the static perioimplantology by Quintessence. So if you Google it, you're gonna find it. So you can order that online. So it's gonna have a lot of cases. Like here, you can see a root coverage case, but we do a lot of things. And this is our website, so implantperio.com.br. So my email, our Facebook line, and I forgot to put here my own Instagram account, but it's Robert Implantiperio. Okay, Robert Implantiperio. So that's it, Omid. I hope you have enjoyed the presentation.
Thank you so much, Robert. Of course I did. You know, as I said at the beginning of the presentation, I was pretty sure that you will again show a fantastic case presentation to all of us. And you know, it's, as you said, it's not easy at all, and it really needs a learning curve, and it really needs to have every detail of the procedure in one place. Because if, as you exactly said, that if we miss one part, the risk of complication and failure are going to increase significantly. So thank you for being that clear on the topic. Actually, I think that topic is so much interesting. We can talk about it for hours and hours, but I want to keep it short. First of all, it's I know it's just an idea, but I want to know, is your preference for fixing the non-resorbable reinforced membranes is always using screws, or also using tags are possible to fix the non-resorbable reinforced membranes?
No, my first choice for sure is the screws, because they are very easy to place. They are self-drilling, okay, self-tapping, and that avoids the tapping of the patient. But sometimes the bone is not good, is not so stable, so I have to use the tacks. So I use the tacks whenever I need them to be used, but the first choice for sure are the screws. If you ask any patient that goes through a horizontal ridge augmentation, okay, so what is the worst part of the surgery? I can make a bet with you here right now that they're gonna say the tapping, because the hammering, especially if you use stronger tacks, it's very heavy for the patient. So that is why I prefer much better the screws, because the non-resorbable material will not rotate when you use the screws, as opposed to the resorbable material that if you try to use a screw, it will rotate. It's going to spin the membrane. So using this kind of material, I prefer much better the screws.
You know, the reason that I asked, because I in my experience, I think using tags in fixing the non-resorbable membranes alone, maybe they're not stable for long term and they may get loose. And but the screws won't get loose. So maybe that's one of the other priorities for screws comparing to tags.
But listen, it's very important to have a good feel of the tightening of the screw, because it might get loose. So it's very important that when you are, rotating the screw into the bone, that in the end you really feel it getting tighter. Because if it doesn't get that tight, you might want to use the tacks, because the screw might get loose. And if the membrane if it get looses, you might have some complication, because the membrane is gonna move and the soft tissue can get in and the bone can go out and stuff like that. So it's very, very important that the stabilization of the membrane is very well performed. It's like a key element to the regeneration. Yeah. And of course that the tightening of the screw is good. If not, use tacks.
Yeah. And Robert, regarding the choosing the proper size of the membrane, the reinforced ones, because for example, especially in the defects that we need to do the augmentation on the palatal side and the buccal side, and for mesiodistal we can measure, but For this curved area that we need to have the proper size of the membrane to make sure it covers every aspect. Do you have any recommendation for our audience?
That is exactly why I mentioned that I really like to use the printed model to use prior to the surgery, because you can have a very, very good view of the defect configuration, number one. And number two, you are able to wax the defect. And by doing that, you can then play with like a kind of foil. So for instance, here, let me show you this. What is it? Here. This is I'm in my office right now. So here I have different sizes of membrane, but this is only paper, okay? But they are 4 by 5, 3 by 4 centimeters. There are other sides here that I use on top of the waxed models, printed models that I like to play with. Just a second. Rose, pega modelo para mim rapidinho, por favor. Qualquer modelo, modelo de cirurgia. Qualquer modelo, modelo de cirurgia para mim. Qualquer guiada. So I'm asking my secretary now, because this is routine in my office. So I get the printed models, then I wax them, then I use those templates here to cover. Não, Rose, modelo de regeneração que eu faço isso aqui. So that I do this kind of play, and I do several times. I cut and recut, and one way, other way, different sizes, until I have the proper feeling that it's completely covered in the best way. So here, so this is my next. So this is going to be my next surgery. This is next week surgery. So the posterior mandible. So I have to wax this area right now, and then I go playing with the membrane like this and making the configurations to cover perfectly and find the best size and the best shape to the membrane. Because this is very important, Omid, because if you are going to do that during the surgery, and I know many people do that, but to be honest with you, I feel that I don't have the ability to do that during the surgery. I think it's very difficult to trim, to cut. So I like to play with that with calm, easy in my office. And I try one, and I try two, and I try 3 times until I'm okay. And when I'm okay, this will be already trimmed here. I put this to sterilization, and at the time of the surgery, I just cut it very easily. And of course, some minor adjustments are necessary, but it makes my life easier, number one. And number two, it prevents infection. Because imagine yourself during the surgery doing a very, very important step, which is the trimming of the membrane. If you lose your concentration, you can touch anything, and then you touch the membrane. And that contamination of your gloves touching some area that should not be touching, like your loops or whatever, then that contamination will be delivered to the membrane, and that can cause infection. So by doing that previously, it makes your life easier, safer, and prevent a lot of complications.
Yeah, I think that was one of the greatest advices that we could have by having the model prior to the procedure, because as you said, it's not really easy to shape the membrane, the non-resorbable ones, during the procedure, and so many complicated things can happen. And one of the other things in your re-entry, because for example, you built like 4 or 5 millimeters vertically in combination of xenografts and autografts, when you want to place your implants, for prediction of a specific amount of bone resorption that might happen in future, do you prefer to place your implants in the augmented bone subcrystally or not? And if so, how many millimeters you prefer to place your implants subcrestal?
So I always like to put the implant subcrestal, okay, to kind of protect the cervical region of my implant. I don't want to have that exposed without the bone, so that may cause complications. But I really trust the augmented bone. So I try to think as if I was drilling, pristine bone, non-augmented. So I always like my implant to be like 4 millimeters distant to the future cervical region of the restoration. So that will provide me like 3 millimeters of soft tissue and 1 millimeter subcrestal, for instance. Okay, so 4 millimeters, 4.45 sometimes millimeters apical to the future gingival margin. And if I'm placing the implant in the regenerated bone and I feel that the bone is a little bit loose, so maybe it's better to scrape off that loose bone and cover with a new layer of xenograft or with autologous bone and wait some extra months in a way that you may give some time for this new graft to take and to be reconstituted with new bone of the patient. And that is my recommendation. So I have to trust that the bone that I created is good enough. And of course that I have to be honest with myself. When I'm drilling, I'm taking that into consideration. But pretty much, I think as it was in terms of the positioning, I think as it was pristine bone.
Yeah, great point. And Robert, one last thing that I wanted to ask you is regarding the very thin layer, something like periosteum that sometimes happens to be underneath the non-resorbable membranes at the time of removal. Actually, you mentioned that sometimes from the adjacent area, there might be an area for soft tissue migration, but sometimes we see it all the way, not only from the adjacent parts. So in those cases, when you face that periosteum-like tissue, very thin, do you prefer to remove it or you prefer to keep it?
It depends on what I'm going to do later. So if I'm placing the bone, I'm placing the implant through this periosteum-like non-collagenic tissue, so to speak, okay? I'm placing the implant. And if I want to place a little bit of more bone, then I scrape everything off, including this soft bone, not only the soft tissue, but also the soft bone, in a way that I can place my new layer of grafting, which is bone, on top of the good bone that has formed. But if I'm happy with the bone that it's there, and I only see a small layer of this kind of periosteum-like tissue there, and I'm going to place just a connective tissue, I don't have to remove it. I just keep it there because there is nothing bad about that layer of soft tissue.
Yeah, great. Because it was kind of a discussion in so many sessions that some people said that maybe that thin layer of periosteum-like tissue keeps saving the bone, but as you said, it depends on the case, and if it's soft, if you want to do the graft, it's important to remove it. Robert,
just one thing, the etiology of this tissue. We have to think about the etiology of that tissue. So it was very interesting to see in my case that in the buccal area, I didn't see any of that tissue. Yeah. And in the palatal area, we saw a little bit of layer of that. So what is the etiology of that? In that case, for sure, in my opinion, it was the mobility caused by the tongue of the patient putting pressure there. So it has been said by Massimo Simeone that that layer of tissue is either related with some micro movimentation of the membrane that prevents the bone to touch or the regeneration to take place to the level of the membrane, or it can be related to some soft tissue growth from the adjacent regions. So this is why I always like to place a collagen membrane covering the edges of my membrane, of the real membrane. And you could see in the buccal area, there was no soft tissue layer. But in the palatal area, because the tongue, maybe, I think, I had that kind of micromobility. And that is the source of that, tissue that was there.
Thank you. Thank you, Robert, so much for your time. Actually, I really, again, have to say, I truly enjoyed, first of all, your amazing case, as all of your cases, but the way that you went through every steps, detail by detail for everybody. So I think it was crystal clear for everyone, those steps and the message that you delivered. Thank you for accepting. Thank you for joining, and really looking forward to welcoming you in my country, Iran, very soon, hopefully next year. And for everybody interested in regeneration, I truly recommend you all to Google this amazing book by Quintessence, Aesthetic Peri-Implantology, for more information, tons of beautiful cases, and you can review them all the time in your office, at your home, and learn from one of the best educators that we have in the field of implant dentistry. Hope you stay safe, my friend. Thank you.
Thank you so much, and looking forward to seeing you in the near future in your country, as you said.
Sure, absolutely. Take care.
Bye-bye.
Bye.
Be safe.